Our next late-breaking clinical trial is titled Magnitude and Duration of Effects of a Short Interfering RNA Targeting Lipoprotein a placebo-controlled, double-blind, dose-ranging trial. It's referred to as the Apollo trial, and it will be presented by Stephen Nissen. Dr. Nissen.
Thank you, Dr. Kerfman. Panelists and colleagues, it's a pleasure on behalf of the Apollo investigators to present the results of this single ascending dose study of a short interfering RNA targeting lipoprotein A. My disclosures are shown here, but I do not accept any personal payment from industry. Lipoprotein A is a very important risk factor for ASCVD and aortic stenosis with no treatments approved by regulatory authorities. There are 64 million Americans and 1.4 billion people on the planet that have elevated levels. The LPA gene encodes for apolipoprotein a dominant rate-limiting component in the hepatic synthesis of LPA. An siRNA is a double-stranded RNA designed to degrade a specific messenger RNA to suppress the translation of a target gene. The phase 1 Apollo trial examined the tolerability and LPA lowering effects of SLN360. This is produced by Silence Therapeutics, a UK company. And this is an siRNA targeting the messenger RNA specific for the LPA gene. To explain how this type of drug works, please follow the numbers. The LPA gene is transcribed. The messenger RNA is produced. A short interfering RNA is a double-stranded RNA attached to a sugar known as GalNAc, which is actively taken up by the liver. Then the double-stranded DNA or RNA cleaves, and a guide strand degrades messenger RNA, preventing the production of ApoA, which prevents the production of lipoprotein a. This study was performed in adults greater than 18 years in age without known ASCVD and an LPA concentration greater than 150 nanomoles per liter. Single-dose cohorts were randomized to doses from 30 to 600 milligrams or placebo given subcutaneously. These participants were monitored in a clinical research unit for 24 hours and then seen periodically out to 150 days after dosing. This is how the study worked from a schematic point of view. Each cohort was studied, and a safety review committee then permitted us to escalate to the next higher dose, and that was progressively performed until we got to the 600 milligram dose. Everybody was followed for 150 days, but our safety review committee advised us to follow these patients in the highest dose group for 365 days. Like all phase 1 studies, the safety was of paramount importance. Physical examination, lab chemistries, treatment emergent adverse events were collected. The primary endpoint was the effect on lipoprotein A concentration from baseline to 150 days, and we also measured other lipid parameters and inflammatory markers. These patients were about 50 years in age. Their median LPA concentration was very high. It was 224 nanomoles per liter. This is the principal efficacy measure. There was a dose-dependent reduction in lipoprotein A, and at the top 2 doses, there was nearly complete elimination of LPA from the plasma. I will show you this as a % reduction in the next slide, but please also note that these reductions were maintained out to about 150 days. We don't have data beyond 150 days, but we will when the 365-day data is completed. Taken as a median percent lowering of lipoprotein A, the 300 milligram dose achieved a nadir of 96% reduction. The 600 milligram dose produced a nadir of 98% reduction. At 150 days, the top dose was still 81% below baseline, and the next higher dose was about 70% below baseline. SLN 360 also reduced LDL. I'm showing you only the top 2 doses for clarity. Lesser effects were observed at lower doses, and there was a 21 to 26% reduction, dose-dependent, in the 2 highest doses in LDL cholesterol. ApoB was also reduced, 24% in the top dose, 21% in the 300 milligram dose. And also please note that these reductions appeared to persist out to about 150 days. Now, in phase 1, safety is very important. We really didn't see significant safety events. There was a single patient that had a serious adverse event that we thought was really unrelated to study drug. It occurred at the 30 milligram dose, and you can see details about this in the manuscript that will be online. We also looked at liver enzymes. A single patient, after a COVID vaccination, had a temporary increase in ALT and AST, came back down very quickly, and we do not think that it was consequential. There were low-grade transient injection site reactions, as is seen with all RNA interference therapeutics. These were dose-dependent, they were not severe, and they did not persist. This is clearly a limited study. It was a small, first-in-man, phase 1 trial enrolling only 32 participants. We cannot fully assess safety in a trial of this size and duration. We studied a population without known cardiovascular disease. We don't know what will happen when we study patients with cardiovascular disease. We gave single doses. The effect of multiple doses is uncertain, although a multi-dose study is currently underway. We are very appreciative of the expedited review by JAMA and the excellent editing by the editors. This manuscript will be available immediately on jamanetwork.com, and I would encourage you to read it because there are many more details than I could present today. So in conclusion, subcutaneous injection of an siRNA, SLN 360, targeting messenger RNA for the LPA gene, lowered lipoprotein A up to 98% at the nadir. Greater than 70 and greater than 80% reductions in LPA persisted for 150 days after the 300 milligram and 600 milligram doses, respectively. The highest doses reduced LDL and ApoB in the range of 20 to 30%. There were no major safety issues, although low-grade, transient, dose-dependent injection site reactions did occur. We think these findings support further development of this therapy, which is underway. Let me leave you with a final thought. Historically, elevated lipoprotein A has been considered an untreatable abnormality, and it's frequently not measured by many of our colleagues. The development of therapies targeting messenger RNA has made possible significant lowering of LPA. Whether these reductions can impact on the incidence of ASCVD or prevent progression of aortic stenosis remains to be determined, but we think that optimism is warranted. Thank you so much for your attention.